Hello, everyone. My name is Rodrigo Sánchez Bayona. I'm a medical oncologist from Hospital Universitario 12 de Octubre. And we're here at the San Antonio Breast Cancer Symposium 2025. We just came out from the General Session 1, in which the HER2 positive advanced breast cancer has been one of the leading topics that we've been discussed today, with a very important readout of the HER2CLIMB-05 phase 3 clinical trial. In the recent 2 years, we have witnessed at least 3 clinical trials in the first line HER2 positive metastatic breast cancer setting. The 3 of them have been positive. So this HER2CLIMB-05 trial comes to add to this list of positive clinical trials in the first line setting. What's the added value of the HER2CLIMB-05 in this phase 3 trial? Patients that were previously treated with induction chemotherapy with taxane, trastuzumab and pertuzumab, at least between 4 or 8 cycles and did not progress, were treated in a maintenance phase with tucatinib versus placebo and trastuzumab pertuzumab. More than 600 patients were randomized 1-to-1 in the trial, and patients with baseline brain mets were allowed to be included in the study. We saw today the first analysis of the trial. It was a positive study with a median PFS of 25 months for the tucatinib arm compared to 16 months in the placebo arm. This is relevant because now we have many options in the first line setting. If we remember 2 years ago, we saw the results of the PATINA trial, the addition of palbociclib in the maintenance phase for hormone receptor positive, HER2 positive patients, with astonishing results of median PFS of more than 40 months. And very recently, in this ASCO Congress this year, we saw the results of the DESTINY Breast 09 trial with TDXD plus pertuzumab in the first line. So currently, the algorithm in the first line HER2 positive advanced breast cancer is getting more and more complex, and there are some pros and cons in how we're going to be deciding which treatment is most optimal for our patients. Probably we cannot compare, of course, and we cannot do cross-trial comparisons, because in terms of median PFS, we cannot compare directly DB09, PATINA, and HER2CLIMB-05, because the time from randomization to PFS is different among the 3 trials. In the DESTINY Breast 09, it was time from randomization to progression, but in PATINA and in HER2CLIMB-05, it was after induction taxane chemotherapy plus trastuzumab and pertuzumab, so we cannot make direct comparisons in terms of median PFS. But what is interesting is that now we have 3 different options: one more chemo-like with trastuzumab deruxtecan and pertuzumab in the DB09, and 2 options without chemotherapy in the maintenance phase with palbociclib for hormone receptor positive, HER2 positive patients, and now we have the option of adding tucatinib. In the subgroup analysis, the benefit was quite consistent with the addition of tucatinib, irrespective of the positivity of the hormone positivity of the hormone receptor status, but probably for those patients with ER-negative disease, the addition of tucatinib could even prevent the development or the early progression of the disease. There is still one open question that remains still unanswered, is that how can we prevent the incidence of brain metastases? Because in the HER2CLIMB-05 trial that we saw the data today, the number of events in terms of CNS progression was still quite small, so we don't have very robust evidence to clearly say that tucatinib could prevent the development of CNS disease, of brain metastases. So probably upcoming data will show, will add more light on this, if what is the added value of these new TKIs, or if the ADCs like trastuzumab deruxtecan can prevent the incidence of new brain metastases in patients without brain mets at baseline. So as a conclusion, HER2CLIMB-05 adds new evidence that the standard of care in the first line in HER2 positive advanced breast cancer is becoming more and more complex, and probably this is good news for our patients, because we can personalize the treatment depending on different factors and patient preferences. Thank you very much.